what you call the health facilities that are at the bases. It focuses mainly on the military hospitals. We have 3, 1 military, 2 military, and 3 military. All right. Let me welcome all of you to the meeting, and welcome specifically the Surgeon General, Lieutenant Mapaha, sorry, Lieutenant General Mapaha, who's the head of the chief of the South African Military Health Services. I'm mentioning his name because I saw it on the screen, and I don't know who else is there from the department. Maybe let's deal with the apologies. I will then come back to the attendance so that I confirm the attendance on the side of the department. May you let us take apologies. Are there any apologies?
Good evening, Chair. Good evening to all the members. I've got 3 apologies from the Minister, from the Acting Secretary, and from the Chief of Staff, Chair. Those are the 3 that I have. Thank you.
Okay. Thank you very much. So, is the Deputy Minister on the platform? Have you seen him?
Honorable Chair and committee
Yes,
members, good evening.
Good evening.
I am indeed in the house.
Thank you very much, DM. We welcome you to the meeting. Thank you much for your presence, your attendance. Thanks, DM. All right, colleagues, having noted the presence of the colleagues, that there are 3 apologies. Is the Acting Secretary, the Chief of Staff, as well as the Minister. Those are the 3 apologies on the side of the department. Committee side, I don't know, recorded apologies?
No, nothing, Chair.
Nothing. But do you have the quorum?
Yes, we do, Chair.
All right. Understand, Nandipa, you will be experiencing load shedding at 8 o'clock. And you have requested that if the system kicks you out, that Velem takes over. So we note that. I'm also having a similar, I will be having a similar situation on this side. From 6, it's already 6 now. If the system kicks me out, Honorable Thabo will take over. Are you in the meeting, Honorable Thabo?
Chair, I don't see him on the list of participants.
Oh yes. Oh no, he's there. It's just joined.
Okay.
No, thank you so much. Thabo?
But don't worry, Chair. If we lose you, we will go on. No problem.
That's fine. But I want to leave them in safer hands, not in your hand. Yeah.
Safer hands. Can't get safer than me.
Yeah, no, that wasn't just Mr. Colleagues. No, thank you so much. Having verified that we do have the quorum, I will then check with the lieutenant if he's ready to take us through the presentation, and the DM will come to wind up the discussion towards the end. of the presentation or the discussion on the presentation. Lieutenant, you will then acknowledge all the team that is in the meeting, team members that are in the meeting to support you. Over to you, Lieutenant General Mapa, the Surgeon General.
Thank you, Chairperson, and the Deputy Minister, and all the members of the committee. With me, I am with the Director Planning, Brigadier General Langa.
Would you mind setting your video on?
Oh,
Unless you think it will interfere with the thing. All right.
you can see
Okay.
me.
We can
Yes.
see you, General.
Yeah, as I've said, I'm with the Director Planning, Brigadier General Langa. I was supposed to be joined by the Chief Director, Force Preparation, Major General Simelane. I don't see him right now. We are not in the same place, as well as the Chief Director for Support, Major General Kosana. I don't see both of them. That would be important because we're not in the same place. At the moment, I'm currently load shedding, but I made sure that probably will be covered for the duration. So the presentation will be done by Brigadier General Langa, Director Planning. We will outline the mandate of the SAMS, what we are responsible for. Then we will go into the challenges. And then on top of the challenges, we will try and outline some of the achievements that we have achieved despite the shortcomings. And then we will also outline some of the measures that we are putting in place in order to mitigate the rampant outsourcing. And then in the end, we will outline the requirements and the costs thereof. So, Chair, if you will allow me, I will hand over to General Langa to start with the presentation.
Thank you very much, General. General Langa, over to you.
Thank you, Chair. Thank you, SG. I'm just going to take a moment to load my presentation.
Yes, we will wait for you. You now have the whole the sharing rights. There's CDM. There's a hand CD, so CDM Chief Director, Military Health FP. I don't know what FP stands for. Is your hand up, Chief Director?
Yes, Chief Director, Military Health Preparation. Just to let the
post preparation. Okay.
Yes.
And the name is
General be aware that I've joined the meeting.
The name is
Major General Simelane.
Oh, Major General Simelane. Oh yes, he did mention your name. Welcome, yes. Major General Simelane. Thank you very much. Over to you, General Langa.
Thank you, Chair. Thank you, SG. Deputy Minister, members of the Joint Standing Committee on Defense, good evening. As Surgeon General has mentioned, I'm Brigadier General Langa. I'll be taking you through the presentation. That is the aim. I'm not going to dwell on that. That is the scope and layout. I think SG has taken you through the scope. And I would like to just perhaps start with the mandate to say the SAMS derives its mandate from the Defense Act. And Chapter 15 of the Defense Act talks about general regulation. And those general regulations determine that the SAMS must at all times be structured and funded at state cost to provide an all-inclusive multidisciplinary health capability to the South African National Defence Force and its members. And that is provided that the cost of those services to serving members shall be the liability of the state. So are we saying this military health services is structured and funded? I think that answer will be provided as we go along. In terms of that, the general regulations, therefore, healthcare services to the military community is regarded as a contractual obligation and an operational standard. And from where we're sitting as a SAMS, we'd like to believe that we provide in the mandate in terms of providing an all-inclusive multidisciplinary healthcare capability to the SNDF, but that our challenge is providing an affordable and quality healthcare services within the limitation of what we allocated. In terms of our purpose, we provide prepared and sustained capabilities and services in defense and protection of the Republic, in support of the Navy, in support of the Army, and in support of the Air Force and joint operations. There are two outputs expected out of the SAMS. Output number one is the joint force employment output, and that output has to do with support to joint force employment, support operations. Output number two talks about base-oriented support, and that talks to the 86 base spread across the length and breadth of the country, the 5 base hospitals, as well as the 3 tertiary hospitals. They all form part of the output 2, which is a base-oriented support. Output 1 is our primary responsibility, support to joint force employment, and output 2 is a secondary responsibility. In terms of the joint force employment, we support the 10 priority mission of the SNDF. Those missions are under the command of joint operations. We support the Navy, the Air Force, and the Army. We support the 10 missions through 3 reserve force medical battalions and 2 regular force battalions. Now, our challenge with supporting the joint force employment has to do with the lack of joint force employment capability for us to be able to support the 10 missions. In other words, we don't have dedicated structure for each of these missions. If we require to go and support mission number 9, that is support to other government departments like strikes, we have to pull people from the hospitals and from the sick bay to go and support mission 9. So there are no dedicated capability, medical health capability for the 10 missions. The conventional capability of the SAMS, which is 8 medical battalion, that is supposed to be supporting the mission in Mozambique and the mission in DRC, operates on a virtual structure. Once again, if we need to send people to go and support our troops in DRC and Mozambique, we have to draw from the sick base and the hospitals. In terms of base-oriented support, we provide it through 3 layers. Layer number 1 is through the tertiary hospitals, your 1 mil, your 2 mil, and your 3 mil. We also provide primary health capabilities. And that is done through the 86 clinics that are dispersed across the country, as well as 5 operational base hospitals. And we also provided through the base-oriented support. We provide support to the presidency or the presidential medical team. And that also includes heads of states that are on visit to the country. Our challenges with that output-based oriented support, we provide support to military veterans, and the challenge there is that we're supposed to be getting reimbursed for the services we provide to the veterans, and unfortunately that has not been working properly. There's still an amount of money that is owed to us for us to be able really to provide support, not just for the veterans, but for the base-oriented support, because we draw resources from those programs. There's also the challenge of the SNDF that has to do with the military population that is getting old. Our soldiers are getting old, And as you are aware, when people get old, they become more expensive to maintain. And that requires money, that requires budget, that requires medication. And the other challenge that are creating problems for the base-oriented support, as I mentioned in the previous slide, has to do with the joint force employment, because the requirements for us to engage in deployment is increasing. We're now in Mozambique, we're now in DRC, that requires bodies. We're also in the border, that requires bodies. And those bodies are coming from the sick bay and the hospital. So this increasing joint force employment are creating a bit of an issue with our sick bays, because then you're sitting with long queues and so forth. In terms of the DVIP, as I mentioned, that is support to the presidency through the Presidential Medical Unit. And in terms of our support to the Presidential Medical Unit, we support the incumbent as well as the retired RSA head of state, all retired RSA head of states. We provide support to the incumbent deputy president as well as all retired deputy presidents. As I mentioned in the previous slide, we provide support to all heads of state visiting South Africa. The challenges with that kind of support or this kind of capability is that Presidential Medical Unit doesn't have a structure. It operates on a virtual structure. Once again, personnel are drawn from sick bays and hospitals, which creates its own dynamics. Because it operates on a virtual structure, it is not funded. The other challenge is that the commitment for PMU increases with this new administration, while we're not given the opportunity to expand the structure in 1 million the sick base, so that at least we're able to close gaps. In terms of the challenges with personnel, and that talks to the hospital, that talks to the 3 tertiary hospitals, as well as the 5 base hospitals. The SNDF structure, as we speak today, the approved structure is 73,153. The foot on the ground, that means the funded post is 64,567, which leaves us with a gap of 8,586 unfunded posts for the SNDF. For the SEMS, the approved structure is 10,748. The funded structure, feet on the ground, not feet on the ground, the funded structure is 6,612, which means the SEMS has got a deficit of 4,138. It's got unfunded posts of equaling 4,138, which implies that we're operating at 62% capacity of our approved structure. The issue is, out of the 8,000 unfunded posts in the total National Defence Force, half of those unfunded posts are in the SEMS. Out of the 8,586 unfunded posts in the SNDF, 4,000 are in the SEMS. That's a challenge. The other challenge that we're experiencing in terms of that structure is that these cuts are normally not discussed with us. They are unilaterally just being told, or next year, you must cut by this much, without considering the impact on service delivery. And this impact, obviously, it contributes to outsourcing, because if we're not able to get enough people to man the beds in our hospital, SG has got no option but to outsource. We would want to provide 24 hours for the hospitals, both your tertiary hospitals and your base hospitals. But at current capacity level, the 6,612, we're not in a position to provide 24-hour service without the use of overtime. So we're forced to make use of overtime. Otherwise, you're not going to be able to run the hospital on a 24-hour basis. In terms of the structure, as I've mentioned, the structure is not sufficient. The current structure of 11,000 was created in 2000. 30 years down the line, the same structure is 6,000. The patient load has increased threefold, and that creates its own problem. So the current healthcare practitioner and patient ratio, they don't just correlate. And then if you factor the joint force employment requirements, it even makes it worse. I spoke about the issue of the presidential medical team that operates on a virtual structure. that add onto the challenges in terms of capacity of the military health. So it's really becoming difficult for us to be able to meet the demand of the joint force employment and to simultaneously render base healthcare services. It's just not sustainable. Furthermore, the same structure does not have regular force protection posts. We don't have protection like the army and the others. We rely on reserve force call-up for us to be able to provide protection for the hospitals, your tertiary hospitals and your base hospital. The challenge with that is that the previous 3 years has seen a substantial cut in reserve force cost of employee, the budget, resulting in the reduction of man-days, which leaves our hospital then without protection, which creates its own dynamics. In terms of sustainment, we've also seen in the past 5 years an exponential increase in the number and cost of healthcare outsourcing, including medicine buyouts. We're sending people to go and buy medication outside because we're simply not able to stock. That has to do with the poor health standard of our facilities, especially outsourcing, healthcare outsourcing. That has to do with the old equipment in our hospitals. We don't have technology. We run out of medication. Half year, down the line in the financial year, we run out of medication. We have to go to DPPAC to go and beg for money. We're simply not getting enough funding for us to buy medication to sustain us for the year. The other challenge that contributes to outsourcing is the shortage of healthcare practitioners, especially medical specialists, because then we're not able to perform some of the operations, some of the procedures in one mill. So in the hospital, as a result, patients have to be outsourced to other hospitals. I mentioned the issue of us not being able to sustain stock level because of budget, obviously, and the lack of cold chain capability or capacity at the medical base depot. But the lack of our inability to sustain stock level mostly has to do with the insufficient budget allocation. In terms of training, and that talks to soldier in training, our military courses. In 2020, all of you, as you are aware, we had a challenge with COVID-19 in the country, which restricted traditional face-to-face classroom attendance. And that contributed to a lot of backlog in terms of our military training. And that also has an impact in terms of the combat readiness levels. We're having challenges with that combat readiness level. We tried to mitigate that by trying to schedule more courses at the training formation that is in Tabatswani. The past 2 years, the training formation has seen a lot of things. So the area, the facility or the formation is sitting in a dolomitic area of Tabatswani. And the past 2 years, the training formation has been experiencing sinkholes, which then poses an occupational risk. So we're not in a position to schedule the number of courses that would want to schedule. We then relocated some of the courses to Lephalale because that's where we're doing our basic training. But unfortunately, the facility in Lephalale does not have enough capacity for us to schedule sufficient courses to be able to address the backlog. So we're sitting with a number of people that require to do military courses, and that is impacting on people that are made available for the joint force employment. In terms of equipment, for us, this is a big issue. Our equipment in the hospital is very old. Because it is very old, it requires constant repairs and servicing. And sometimes the process of repair and calibration takes long because there are no spares. You battle to find spares because the equipment is quite old. That results in delays in the hospitals for patients to get the necessary attention and intervention. Delays and waiting times has got their own implication in that they put patients at risk of complication and even loss of life. The other issue with the old equipment is that our military hospitals are designated training routes for junior doctors with regard to 2,000 community service. And if the equipment is old, you risk losing accreditation for that hospital as a training institution or academic institution. and the Health Professions Council. And that in itself has got a direct impact on job satisfaction of our members, the standard of care, the retention of those people, as well as the on-the-job training. We're also experiencing a shortage of ambulances, and as a result, our ambulance services are contracted to private service providers. The last time I think we acquired ambulance in the sense of procured ambulance was in 2010. We would also want to provide a 24-hour service for ambulatory services, 24-hour ambulatory service for the hospital. But because we don't have enough ambulances, we're not able to render that service, and as a result, we have to outsource those services. In terms of facility, the issue of 1 mil is a big issue for the SANS because it's really contributing to our financial woes. 1 mil, Hoedspruit Base Hospital, as well as Lohatla Sick Bay, the South African Army Combat Center in Lohatla. The facilities are quite bad. They require significant repairs and maintenance, and they are therefore not in compliance with the national norms and standard. And like the equipment, if the facilities don't meet the norms and standard, we risk losing accreditation for those facilities as training or academic training facilities. And once again, that also impacts on the job satisfaction, the standard of care we provide to our members, as well as retention, whether we can retain our healthcare workers. We already lost a number of specialists because the facilities are not compliant with the norms and standard. And that in itself contributes to increased healthcare outsourcing, because if the facility is not up to standard, we're not able to house patients. We're not able to keep patients in those facilities and monitor them. So these patients will have to be outsourced and monitored in those hospitals. In terms of the information system, the SANDF defense system is very archaic and is paper-based. For the medical service, that is a serious drawback in terms of how we deliver our service to the patients. And that also has got its own implication in terms of, litigation. We've lost a lot of cases because we simply couldn't find records. Because remember, this information or files are paper-based. So records, tend to disappear or get lost. And when you have to go and defend a case, you lose it because you don't have records. And you also have our people spending more time really doing administrative tasks than they should be engaging in value-added tasks, because the information system is very archaic. It takes a lot out of the people. In terms of technology, we still lag behind in terms of technology compared to other public hospitals. And I'm thinking here of your Steve Bikos, your Grooteskier, your Inkosi Albert Luthuli. Those are public hospitals, tertiary hospitals. We far behind them in terms of technology. Our current healthcare infrastructure still functions in silos with old legacy system or devices limiting functionality and interoperability with new technology. So you buy a new technology, but because the infrastructure is so old, you have a challenge with compatibility. In terms of the legal, the department, like the Department of Health, faces millions annually in claims against or due to medical negligence or alleged medical negligence. If I may just give you a picture in terms of the statistics as on 31 March 2023, the total number of medical claims against our hospitals, both tertiary and base hospital, is 32 claims, medical claims before court. The total value of those claims is 200 million. The highest claim is 43 million, and that has to do with a death injury. And the categories, this amount of 200 million, the categories are as follows. Failure to diagnose, where patients claim that our healthcare practitioners failed to diagnose, accounts for close to 93 million. birth injury amounts to close to 85 million, and the general claims amounts to close to 23 million. Those failure to diagnose mostly has to do with equipment and technology, because you're not going to be able to diagnose a cancer patient using a stethoscope. You need the latest technology. So if a patient rocks up in 1 mil and you're not able to find anything, you send him back, he comes back 2 weeks, and there is a problem, and he claims that you have been able to diagnose. It's not because the doctor has not done his job. The doctor is in his job, but we haven't the technology to be able to assist, to be able to diagnose some of this condition today. And some of these claims that you're talking about are driven by the quality of healthcare or the perceived lack of services, and in some cases, clinical errors. And those clinical errors, as I mentioned, have to do with equipment and the lack of technology. And it might also be because patients are having high expectations. You know, patients are educated nowadays in terms of their rights. In terms of the budget, the allocation, for us to run the SAMS, in terms of full costing, we would require about 9 billion to run the SAMS optimally. The current allocation is 5.5 billion. In terms of HR, we would have required 6 billion. If we run the SAMS at the approved structure of 11,000, require 6 billion. We currently at the National Treasury reduced cap, we're sitting at over 4 billion. In terms of operating, in terms of operating budget, we sit at approximately 3 billion. And this has got an impact. In terms of the capital budget, you'll see that from 2014, we basically had zero. There's never been money allocated the SAMS from 2014 for us to be able to address equipment and technology in our hospital, which has got an impact in terms of medical inflation, or it doesn't take into account medical inflation, this allocation. It's got an impact in terms of the quality of care that we're supposed to provide. It's got a challenge in terms of the sustainment. I mentioned the issue of the pharmaceuticals. Our facilities are quite dilapidated. And as a result, we're really finding it very, very difficult to attract healthcare practitioners to the SAMS because we're simply not attractive. We cannot compete with the VICO. We're not able to compete with Nkosi Albert Luthuli and Groote Schuur for that matter, and I can name the others. We're sitting at currently 4.5 under funding. And as I mentioned in the previous slide, this funding fails to take into account the inflation, medical inflation specifically, the population growth. In 2000, when the structure was created, we're sitting with something like 120,000 patients. Today, we're sitting with close to 190 patients. And there's also changes in the DoD footprint. In 2000, we were not doing external operations, border operations. We were concentrating on base-oriented support. Those requirements have increased threefold, and the budget was not being met by the budget. And that has got its own challenges. It impacts on the day-to-day unit combat readiness. We're not able to train our people the way we would want to train them. We're not able to do exercises anymore because there's simply no money. We're not able to acquire and retain skills. As I said, we're not competitive enough. We constantly run short of medication. And we're saying, despite all of these challenges, we continue to make contribution to the national agenda, national developmental agenda. 2030, that for the vision of South Africa, just can't see here. To achieve a long and healthy life for all South Africans. You'll recall that in March this year, we were called upon to go and assist the Department of Health during the industrial action by the health workers. The SAMS deployed its personnel to Tshepho Hospital in the Northwest. We deployed personnel to Telemoerane Hospital in Vosloorus, and we deployed our healthcare workers to Sebokeng, And there were also a number of healthcare workers that were deployed in KwaZulu-Natal to go and try to assist them, in spite of all the challenges we're having with the numbers. But when the president knocked on the door to say, I've got a challenge, we're able to say the little that we have, we'll share with the country as part of our contribution to the National Developmental Agenda. We also, as part of the Armed Forces Day this year, we went to Richards Bay, and we came up with a community outreach to say, while we're in Richards Bay for the month of February, we're going to make a contribution to the people of Eshowe and the surrounding villages. We therefore assembled a team of dentists and animal health veterinarians to be part of this community outreach program. And then we're able to conduct close to 18,000 healthcare activities around those 18 villages in Eshowe. And we also deployed our animal doctors to the communities as well. And we conducted about 4,000 activities where we did rabies canine inoculation, rabies for the cats, and so forth as part of our outreach program. Once again, in KZN in July last year, between the 30th of June to 30th July last year, as part of exercise Sherakot that was conducted in conjunction with the Americans, we went out on an outreach program for the local communities in Mhlatuzi municipality, and we visited close to 12 communities there. Again, we deployed dentists and animal doctors to go and do outreach program. And for the dentists alone, they did close to 3,000 activities in those villages. And we also went to go and do animal health activities where we did dog inoculation and cats, and we did close to 1,000 of those activities as part of our outreach program. But perhaps before I go on to the key requirements, I also just want to point out to the committee that we're not just coming here to come and beg for more funding. There are a lot of initiative and intervention be done by the Surgeon General to try to really mitigate so that we're able to forge forward. We know that the country is having challenges in terms of funding, and we're really trying to mitigate. So SG is pursuing both savings and targeted intervention to improve efficiency within the SAMs, within the operating component of the budget, focused on achieving a sustainable SAMs against the current budget allocation. If I may just give an example of what we're trying to do to mitigate. Last year, July, we started with a review of the structure to saying, out of these 6,000, how can we reorganize? How can we repurpose so that we better position to serve our people in the country? The 6,000 that we have, we said, obviously, while we're waiting for politicians and the minister to try to assist wherever they can, let's see what we can. So we're trying to reorganize ourselves within the 6,000 to see how we can better reorganize and be able to deliver the services. That process is almost finished. We're hoping to have it finalized by the end of the month so that we're able to see how we can shift people around so that we're better positioned to serve our people. In terms of outsourcing for the ambulances, I spoke about the issue of us outsourcing ambulance services. SG has also come up with an intervention plan. We started last year. We came up with a plan where between this year and 2025, we're going to be training 300 paramedics. And I can confirm that the first cohort of that 65 is currently at the University of Johannesburg this year. We're hoping by 2025 we would have trained 300. We also, as part of that plan, bought 65 ambulances. We committed 100 million last year to buy 65 ambulances as part of addressing the issue of outsourcing. And we're hoping that from this year onwards, when we get the first cohort, when they qualify, we should start seeing a difference in terms of the number of cases we outsource. We also received about 188 million from National Treasury this year as part of reprioritization from the compensation of employees over time. And we're really hoping to make use of those funds to make sure that we address the issue of equipment, the issue of ambulances, and the issue of deployable equipment. So this money that is been reallocated for the next 3 financial years, we really hope to put it in good use so that we can address some of the challenges that we're having. We already drafted a procurement plan. It's with Treasury. I've got it with me. I can flash it for the committee to see. So we're ready in terms of making sure that we spend the last cent of this money so that we can address these challenges that we're currently facing. In terms of outsourcing, I'm talking about healthcare outsourcing. SG is also implementing a management intervention plan called the Managed Healthcare System. That is, we're coming up with a plan where we're going to be negotiating with what you call designated service providers, specific hospital, so that they're able to assist us with outsourcing at an agreed fee. At this stage, we send in patient, you get a bill, a huge bill. With this approach, we'll be able to have going to an agreement with specific hospital where they agree to charge us at a specific tariff. We already started with the process of training our nurses so that all these patients that are going to be outsourced will be able to make a follow-up so that our patients don't stay for quite a long time in this private hospital, because the biggest cost driver for our outsourcing is actually the hospital stay and not necessarily the procedure. So the case management will be able to help us to make sure that once patients have done the procedure, we're able to monitor them, but as soon as possible, bring that to the 1 mil so that we can monitor them in our hospital. And phase 1 of that plan is going to be implemented from the 1st of August. And we really hope there's going to be huge savings in terms of how much we're paying. Today, for last year's financial year, we spent about 800 million. We're hoping that at least we can have that if we can implement this plan. There's also a plan that we want to roll out in terms of establishing first and second line repairs and maintenance for the health facilities. We're spending a lot of money on bringing private contractors to come and address smaller issues in our hospitals, like a burst pipe, cutting lawns, and then because we don't have cleaners, we don't have cleaners that will be able to take care of the total cleanliness of the hospital, the facilities, and we're spending a lot of money. And we're saying we want to come up with a plan where we can have this in-house. And we feel that if we can build this kind of capacity within the SAMs, we will be able to save, to make a lot of saving in terms of the amount of money that we're currently paying. In terms of that process itself, there is already a pilot project that is running in 1 mil that has proved to be very, very successful. And we therefore want to roll out that process to 3 regions, 1 in Gauteng, 1 in Bloemfontein, and 1 in Cape Town. 1 in Gauteng that will be able to address the challenges within the facilities in Northwest, in Limpopo, in Gauteng, and Mpumalanga. The one that we're going to create in Bloemfontein, we hope is going to be able to address the issues in Bloemfontein, in KZN, in PE, as well as Northern Cape. And we'll have the 3rd one in Cape Town that will be able to address the Cape Town as a whole. And we're hoping to have some kind of a mobile deployable workshop that will be able to visit these areas and address all these smaller challenges so that we can save money that we spend on contractors to come and sort out these smaller issues. 3rd line and 4th line is the responsibility of the works regimen, so we're not worried about that. We're talking about these smaller issues that are really costing a lot of money for us. We also, because I mentioned the issue of the challenges we're experiencing with the reserve force collapse, we want to introduce an electronic surveillance system for our hospital. That system is already installed in 1 mil and in Cape Town, and is proven to be a force multiplier. So it will really address the issue of the continued budget cuts on the cost of employing, the reduction of mandates for the hospital. And yeah, we're hoping this will be able to expand the reach of security staff by extending the eyes and ears into the depth of the facility where they could otherwise, personnel or guards cannot reach. And we're hoping to really save a lot of money once this is implemented across all health facilities. I'm talking about the other hospitals, 3 military hospitals, as well as the 5 base hospital. If I may just then take you back to the presentation, in terms of what we require for us to be able to really manage or run these hospitals optimally, we feel that we need to really acquire and retain our HCPs. We need to look at upgrading our military facilities. We need to look at making sure that we maintain the required stock level. We need to make sure that we can really and be able to repair, do first line and second line repair for our facilities. And we look at acquiring medical equipment as well as technology. And as I mentioned in the previous slide, we need to have force multiplier that can save us a lot of money in the form of electronic surveillance system for our hospitals. How much did it cost us? This is our estimates. In terms of the personnel, you see, we're talking about the 3 tertiary hospitals as well as the base hospital. I know the chairperson made reference to only 1 to 3 mil, but there are also 5 base hospitals that are feeders to the 3 hospitals that we also would like to really look at them as part of addressing the whole question of care. If you look at 1 mil, the challenge there is basically about nurses. It's about people that can go and man the beds. And these are not new posts. We're not trying to expand. These are the numbers within that 4,000 that we're speaking about. Remember, I spoke about the 10,000 approved structure, and the national cap the national treasury cap is 6,000. So this number that you're talking about is within that 11,000. So we're not requesting additional posts. We're saying this is what is required for us to run the hospital, and all we need is for funding to be provided to activate this post. This post exists. So for 1 million, they're looking at about 400 nursing. There's no requirement from 1 million in terms of doctors, and then there's the requirement of specialists. If you look at Khabera, for example, Khabera is a new facility that's supposed to be commissioned as a base hospital. It doesn't have a structure, and for that facility to just be commissioned and start running, we need 181. If we're not able to get this 181, unfortunately, we're not going to be able to run it and operate it because it doesn't have a structure. So all in all, for us to run the 8 hospital, the 3 tertiary and the 5, we're looking at about 1,631 posts. And as I mentioned, these are new posts. The existing funding has just been taken away by Treasury. And we're saying, please assist us so that we can activate them, so that we can really provide the kind of care that we aspire to provide for our members. In terms of the other requirements, as I mentioned, we need a startup. We really need to, we feel we need to establish the in-house capability and workshop for the factotum so that we can take care of our own healthcare facilities. And for that, as a startup, we need 60 million. And that 60 million talks to the mobile workshop and the tools of trade for us to start the business. In terms of ambulances, as I've mentioned, we spent about 100 million last year to procure 65. We would really wish to have another 100 million so that we can add on to the numbers. And I think that will in a way solve our problem. I mentioned the issue of the digital infrastructure of medical equipment. For that, we did quite a bit of money. Obviously, because we've got technology in some of these hospitals, we need to have reliable internet, some kind of a fiber. For us to roll that out, we need about 32 million for all facilities, for the 8 facilities. We need e-learning networks. The idea is that we don't want to be sending our healthcare workers to courses somewhere else. We want to have them, we want them to do courses without leaving the wards, so that doctor doesn't leave the ward to go and do a course somewhere. He can actually sit in the ward and be able to learn and do the courses. And for that to happen, we need about 17 million to set up this network so that they're able to connect with the library and all that. In technology platforms such as our e-health or mobile health, we're looking at about 120 million. That also talks to the bigger sense, not just the hospital, because the hospital needs to be talking to the sick bay. And the sick bay and the hospital needs to be talking to somebody in TRC. So you need the whole connectivity across the continuum of care. For the medical equipment, for us to really get to the level of Steve Biko, because Albert Lituli, Grotowski, and so forth, we're looking at about 370 million. And this is not just small equipment. We're looking at your MRI. That is going to cost you about 35 million each. We're looking at the CT scan. That's going to cost you about 20 million each. So this is big ticket items that we need for us to be able to provide the kind of care that we wish to. In terms of the digitalization of records, remember I spoke about the issue of information system that is archaic and paper-based. We really need to move away from that. And for CMIS and CSAT to roll that out, they're looking at about that kind of amount. All in all, we're looking at about, this is once off about 1.1 billion. Once off for us to be able to get the hospital to a level where we feel we'll be able to provide quality care. So if you look at the estimate of expenditure, the human resource, we're looking at about 1.5. Unfortunately, because the cost of employee, so annually we'll be looking at that kind of those numbers that we spoke about. In terms of the other resources, as I mentioned, it's once off, and this can be provided over a single over multiple years. We're looking at 1.1 billion for us to get the equipment, digitalization, and the ambulance and so forth. In conclusion, I wish to leave the committee with this to say, for us, really, the key functionality, the key to the functionality of the medical health system depends on the following. We need medical infrastructure. We need proper facilities for us to be able to provide the service. Most of our facilities are not there. We need technology in terms of health information, informatics system, as well as medical equipment. We need digital technology. And most importantly, we need human resource that is adequate, that is appropriately skilled, and that is well-resourced. That concludes our presentation. Thank you very much, sir.
Thank you, General Langa. Chairperson, that's our presentation. We are available for any clarifications and respond to any questions that may be posed to us. Thank you.
Thank you very much, General, for the presentation. All right, colleagues. The item is, the presentation is on the table for discussion. But before I open it up for discussion, General, did I hear you well when you said that the last acquisition, ambulance acquisition, was in 2010?
Yes.
Is it how I in 2010?
Yes, we the last proper acquisition was in 2010, and we're not talking about the whole fleet. A few of the ambulances were procured. We were not talking about the ones that we procured last year, late last year and early this year, the 65.
What's the difference between the last year's acquisition and the last acquisition, the 2010 one? I'm trying to understand why you don't say that the last acquisition was last year.
I think the point there was to try and indicate the last time that the SAMS was funded to procure ambulances was in 2010. The ones that we procured last year was through the reallocation within the department, where they reallocated funds to the SAMS after they looked at the expenditure from other services, and then they provided those funds for us.
Oh, I see. And that enabled you to buy how many how many ambulances? 65 ambulances. And I must mention, for the first time, we managed to buy also ICU ambulance. The SAMS had never had ICU ambulances. So late last year and this year, we procured 65, that is in the last financial year, 65 ambulances, which include ICU, mobile clinics, and medium state ambulances. Leaving you with what is deficit in terms of the number that you are looking at having if you were adequately supported?
General Langa does have the figures. Can you provide the figures, please?
Okay. Whilst he's still retrieving the information, I can then ask the other members to ask questions. Mr. Murray and Mr. Rader, I see your hands. Over to
Thank
you.
you. Thank you very much. Thank you very much, Chair. Thank you, General, for the presentation. I want to start off by just checking and making sure that I am understanding the information correctly. In that slide 28, you talk about the estimate of expenditure, the cost, the additional, that I assume that is additional money that you require to basically get to a level where you can deliver the service that you want to. I just wanted to understand when you look at those figures, but you go back to your slide 19, where you had that graph of the budget and what do you actually need. In that graph, the HR that you need is 6.36 and you have got 3.9. So that seems to be already more than what you say you require. So I just wanted to know, how does that figures on slide 28 correlate back to slide 19? And then also for clarity on your slide 24, we are talking about the establishment of in-house capabilities for first and second line workshops and factotums. Where is Defence Works Formation? I understood that is the work that Defence Works Formation will be doing and will be coming in. So I have not heard anything of that. Then I also want to know in your slide 19, where you have given your budget and what you require, what is the medical inflation? What is that index that you are referring to? I assume that is not CPI, in other words, Consumer Price Index. So what are we talking about there? Because that will have a major impact. Then on the funding required, I recall very clearly in the past with our visits to one military hospital that they were saying that to complete the construction and the building, they would need close to R1 billion. I think it was close to that, about 900 million, if I can recall correctly. And then about the same for equipment and technology. So where does that fit in to all this that you have indicated here? I don't see any reference to the RAMP project and what has been required there, and also the progress there. I also just want to know, at yesterday's meeting with the Hawks, we understood that that whole problem and after the Board of Inquiry, that case has been referred to the Hawks, but the Hawks said they know nothing about that. Then to the DG, to the Surgeon General, I just wanted to know from you, I know that you guys are stretched in terms of staff. Has the Deputy Surgeon General already resumed his duties? What is the situation in that regard? Then I have got a question with regards to medical costs. And I know that in the past it has been said to us that the biggest cost, or one of the biggest cost factors in the Department of Defense and the Defense Force is medical SAMS. Now, there are various medical costs, especially on outsourcing. We know that specialists has left us, but then also the ordinary military veterans, the retired members, but also the serving members. How does that work? Is that just a cost to the budget, or do they belong to a medical fund? And what is the situation with regards to the medical fund? I don't know if the Surgeon General can talk about that, because I'm just looking and see if I recall correctly, their employment provides for 100% service and 100% in terms of medicine. So is there a medical fund? How does that work? And does that medical fund, have the capabilities, the financial capabilities to pay for all these additional expenses and increased costs? And also, how does that impact on the bottom line of SAMS? I just need to understand that whole challenge and the impact, especially with regards to serving members and then retired and veterans. Veterans, we know that you are supposed to get refunded from the Department of Military Veterans, which must happen. But in terms of serving members and retired members, that's your responsibility for life, for them and their dependents. Then I just wanted to know from the Surgeon General, we know the situation with the 3 military hospitals, and especially 1 mil, and hopefully you will give us a bit more information now. But with the current budget over the medium term, we know that National Treasury hasn't provided the funding that you require for those 3 military hospitals. What is the alternative? Is there cooperation currently with provincial and other tertiary hospitals to provide the services that you would normally provide in the 3 military hospitals? What would be the situation if you are now forced into a situation that you do not have those 3 military hospitals, those 3 tertiary hospitals at your available for your utilization? How would that impact, and how would you bring in an alternative to that? This is maybe precautionary, but I just wanted to know. And then maybe my last question, Chair, at this stage is, you have indicated of what is the approved strength of 10,748 posts. Now, are you really convinced that those authorized posts is what we actually need? Is that the minimum requirement in terms of what we need? Or can we do maybe better and more with the current just over 6,000 posts? I just wanted to get the comparison between what you want in terms of the approved strength and what you can do in terms of affordability and actual needs, especially if there's a cooperation with provincial hospitals and other tertiary hospitals. Chairperson, the last one is on the private ambulances. I recall I have raised one matter, I think it was a year or 2 ago, about private ambulances where there was a lot of corruption in terms of how they overcharged the Defence Force for services that they have not rendered. And I know that there was a quite strict outcome on that specific case. How do you make sure that those private ambulances do not overcharge us and that there's not corruption involved? Because that can happen very easily. We know about that specific case where they have overcharged us, and if there was not a whistleblower in that case, we would have never known about that case. So how do we stand that to make sure that for those services, that it's actual services, it's essential services, and not just services that they make up and invoice the department? Thank you very much, Chair.
Thank you very much. Mr. Rader.
Yes, good evening, Chair. Good evening, colleagues. Thank you very much for the presentation. I'm going to approach the similar question from a different angle, if I may. So relating to the number of beds, now this is a measure that most hospitals are able to give. So the number of beds available within the South African Medical Health Services, the Military Health Services. What is the number of beds available, and can we get a trend of that over time specifically? So I'd like to see kind of over the last 5 years if we had an increase or decrease, if we can get some sort of a trend. And then in conjunction with that number, another set of numbers which would show the, I don't know if you can call it occupancy rate. So that's more of a hotel term, but how many of those beds were actually needed or used over those periods. So for example, this year we've got 100 beds, of which we've had 60 patients to treat. Last year we had 110 beds with 90 patients or whatever. And then as a third set of figures to tie in with that is the number of staff. You can have a number of staff per bed, or the total number of staff doesn't really make much difference. But just to try and get an idea as well as to whether we are optimally staffed and whether our productivity is in the right space, or whether we losing capacity in terms of the number of people that we're able to treat, or gaining, and then whether the staff complement is moving up or down. In conjunction with that. That's essentially what I'd like to know. Thank you very much, Chair.
Thank you very much. Mr. Mafanya?
Thank you very much. I believe that we can just see I'm under load shedding now.
Okay.
Thanks to Surgeon General for the submissions that he has just given to us. They present a horrible picture to us, but more so that it is almost 4 years that we have been dealing with such kind of issues in the community. And then we haven't come anywhere near to come up with some good results in terms of what has been presented before and now. But the question that I also wanted to know is that during this period of load shedding, in particular, how do you mitigate that, and then how do you survive in terms of that? Because seemingly, if it was according to me, so I am in an ICU. There's a lot that is going on behind the scenes that we are not in our way. More so when you say to us that since 2014, you have been sitting on this time bomb that has never come nowhere near in addressing some of the developments around this. So equally, public hospitals, there's no way we can begin to think that we can take our people, in particular, the same responsibility to public hospitals. They are equally in a mess. And taking into account what you've just told us, that there are no professionals in your area of operation. Equally is the same with public hospitals. There are quite a few of those that you can compare with that are much better than the rest. But the majority of hospitals are in shambles. So it will also be taking our people to go to a deathbed. But the other question that I want to know is that in cases of litigations where there is also malpractices and many other issues that make you put forward the monies that are spent, or is it the money that is already spent, or is it the money that is owed? I would like you to let me on that. It does really feel that SMC is in a disaster situation. If we have to take into consideration that also foreign dignitaries, meaning foreign presidents, also had to downgrade our hospitals. They are no more coming to hospitals for treatment. And they would prefer to go to private hospitals, in as much as you also take some of the patients to private hospitals at a much bigger cost. So the confusion that I have also comes to a point where you say you have taken a number of people for tuition. In 2 years from now, they'll be coming up as proper medics. But they will be coming to the hospital, they'll be deployed to hospitals where there's no equipment. And at the same time, we know some of their professionals left hospitals because there was no equipment. So are we not recycling the same situation where we have professionals that come from universities and medical schools, and they come to hospitals that is not prepared or that doesn't have proper equipment. The case in point is the one military hospital that we were in Tshwane. It was only under pressure where they managed to capacitate, I think it was level 2, with proper equipment. And then the dispensary there, it wasn't on. And I bet that there's nothing that came from there, from the time that we were there. There has never been improvement. So at some point, there's lack of will on the part of the leadership, either from our side, meaning the ministry, that has got to attend to some of this. Because once you present the matter that dates back from 2014, it tells you that there is lack of leadership. And the worst part is that we are dealing with human life. The other question that I would like to pose for you, because you explained about some of the lack of equipment, professionals, also improper diagnosis that people were given. What is the death ratio on the basis of all these things that you articulated? Thank you very much.
Thank you very much, Mr. Mafanya. Mr. Motsomai.
Thank you, Chairperson. Chairperson, I hope you are aware that I've get an accident from one military hospital this Sunday.
This last Sunday?
No, yeah, I just want just not to use my picture. Can I carry on?
You can carry on. I didn't get your introduction. What accident?
I was saying I get an accident when I came from one mil hospital this weekend, this Sunday.
Okay.
That's why I don't want to put my, I like to put my picture on in.
Okay, no, it's fine. You may go ahead, sir.
Okay. Chairperson, you are the overall chair of us in Parliament, in this committee. You are also our director on this committee. That's why sometimes I call you general, because when you take a decision, we cannot turn against your decision. Chairperson, I'm so worried for the full 5 years. We are now covering 5 years. We went to one military hospital and we find it was disaster. People, they've eaten money, more than 150 million. They built only 2 rooms. And since from 2010, in second floor, they are still building it up until today. We were with you. I was in one military hospital this weekend. When you call one military hospital, I can give you the phone numbers now, and you call them. There's no admin. There's no admin. They work from 8 o'clock to 4 o'clock. 4:30, no one will answer your call for the ambulance. They've eaten money, and no one have been prosecuted. No one will have been prosecuted for chowing the public's money. They said they were building that public works. They were having a problem with public works. We will know during this year who been prosecuted. When they come to us, they only come and say, to do this budget. Chairperson, to support the wrong is to oppress the right. When are these people who eat money, who push the corruption, will be arrested? There's no, like now, Chairperson, I say, if you phone to this military sick base, when you're sick, you can't go to hospital on 5 o'clock or 7 o'clock now. They close on 2:30. Friday is worse. When I get in Captain Park on 2:30, there was no one was there. When I went to 21 Battalion, they say it's closed because I was bitten by the mosquito, by a spider. at my place in Cape Town, at Cape Town. I took the car with Mama, said, let's go to Lenesia. No one also in Lenesia sick bay. Because when you phone to them, no one is answering the calls. I have their calls. I said, you can phone now and ask to talk to admin. You want to book somebody sick. You want to bring him at one military hospital. I'm not talking about this Molanyana sick base. When we talk about the serious hospital that our president, Nelson Mandela, you must understand this hospital. It got a very, very serious name, as well recognized. Most of our president, our heroes died on that hospital. Can we say it is the end of one military hospital as we speak? Chairperson, is painful. It's very, very painful. We cannot always say each and everything is being done by the ANC. Let's see these corrupt officials facing justice. Sometimes when I was at the one military hospital, I said, nah, we find this hospital. When we take the hospital on 1994, we took this hospital from the white people, from the regime, but it was good, this hospital. It was not like this. When you get there, when you open the doors, they are simple say, when you close that, you don't close it, it closes itself. It will simply say, in at the second floor. I'm talking about the second floor. Chairperson, the military hospital is leaking. Can't we go there even next week? It's leaking. They put a dish to stop water. I don't know what to say, Chairperson. When these people, they are going to come to us and say, we had arrested those who were committing crime, even those ministers who were there. Today, they are no longer there, but we have arrested this one and this one for the corruption that they've done. I thank you, Chair.
Thank you very much, colleagues. I know, Thabo, I can see Thabo, Motapo, Piers, and Petle. Maybe let me take you in the second round so that you'll also have sufficient time to raise your questions for them to be given adequate responses as well. Do you agree with me if I call you up in the second round?
Yes, Chair.
Thank you very much.
Okay, Chair.
Thank you so much. Colleagues, I think the questions are mouthful. I want us to pose asking questions for now and ask for the department to respond. And in the second round, I will take the hands of the colleagues that I see on the platform. Over to you, General.
Thank you, Chairperson. I don't know if you can allow us to go back to the slideshow so I can refer to some of the slides that Honorable Mare referred to. If you will allow me, Chairperson.
Yes, we can do that.
General Langa, please. 28. I think the first question came from slide number 28. Where Honorable Mare was asking the money that we require there with regards to, if Honorable Mare can clarify, which one are you talking about, human resources or the whole budget that we require as additional?
General, both, because if you just look there, what you say that you require, but when you go back to the slide with the graph, and you see, the red and the green,
sure.
and then you see that those differences are not the same.
Okay.
So I was trying to correlate that and to get to get that to equate.
That is compared to slide number 19, you said.
Correct.
All right, in this slide, Honorable Mare, with regards to human resources, this is for the additional numbers that we require. That 1.5 billion, it's for additional numbers that we require in terms of human resources on top of what we've been given by Treasury. The one of the other resources, this is to get us to a level where we can at least be able to provide the services that we require under the current resources. If we go, I think the slide that you talking about budget, I think it's 19, General Langa.
Yeah, yes, it is. And in general, because obviously that implies that you are not talking about the 10,000 something, as being the approved structure. So how many people are we then talking about? Because that is quite different, that is less than the difference in this slide on HR.
Yeah, let's come here. If you look on the graph, the number on top there, that is the budget, the budget of the SAMs in total, that 5.5 billion. We together. And then if you go in terms of human resources, in order for us to be able to employ that 10,000, we need about 6 billion. But however, due to cuts by National Treasury, our HR budget is that 3.9 for the 600 for the 600 active posts.
Yes, but remember that the difference between that is 2.36 million billion, while you're only wanting 1.2 billion now. So I need to know that numbers. Why is that?
The budget that we require, maybe General Langa, let's go to the slide of the staffing that we require.
There's 1.5 that you require.
Yes, but this one. This one.
Yeah, now, that's 1.5 billion.
Yes. Remember, we indicated that the approved structure of the SAMs is about 10,000.
Yes.
And currently we are operating at 6,000.
Correct.
That takes you back to that 3.9 billion to fund that 6,000.
Sorry, General. Sorry. I don't want to be left behind. What is the funded post? How many funded posts is in the department?
6,000.
6,000. Approximately 6,000.
Approximately 6,000.
Yes.
So, when your requirement is 10,000 plus.
That's a chairperson. That's the approved structure.
It's
but obviously what the general is now saying, they actually need over and above the 6,000. They need another 1,631. Am I correct?
Exactly.
And, yeah.
We are not saying give us the 4,000.
No, Mr. Mare, just wait a minute. Just wait a minute. It's 6,000 funded when when the approved structure is 10,000 plus.
Correct.
Yes.
Right. Meaning that the difference is about 4,000.
Yes.
Okay. Is this 1,681 within the 4,000?
No.
Yes.
Over and above that.
No. I thought that was the question, Mr. Mare. I thought that was the question. That's why I'm focusing on it. Is this 1,631 within the 4,000 plus?
Correct.
Yes.
That you
yes.
Correct.
That will require funding for.
Yes.
Exactly.
Yes. So in other words, it's still less than the 10,000, but it's a 6,000 plus 1,600 posts, and that's why it is still less than the approved posts. In other words, this is a kind of compromise situation then from the Surgeon General side to say, I can get away with less, but I at least need this additional.
Yes. I think that's what he says, is that
Yes. Yes.
currently they are funded at this level, but if we can get these 1,631, it will
That's
take
right.
us somewhere.
Yes. Yes. That's now been clear. That's now been
Alright.
clear to me. So thank you for that one. Much appreciated.
Do we
Maybe to
agree
just,
that that is the minimum? That's a minimum
Yes.
number that could actually take you somewhere, even if you did not get funded up to the full complement.
And yes. So you are right. We're in the same page. This
Yeah.
1,600 is within that 4,000 that we are not funded for.
Okay.
Okay,
And
no, that's
bear
fine.
in
So-
mind, this 1,631, it's not only healthcare professionals, it includes support personnel.
Yes, we
Yes.
saw it.
Yeah.
Exactly. So on top of the HR budget that we have been allocated for, if we are given this 1.5, it will take us to somewhere where we feel we will be able to provide at least a service that we will want to give to our clients.
Okay,
Right.
no, that's understood.
Yes, and then slide 24. Slide 24, in case you were asking about in-house capability. Slide
Yeah.
24.
Yeah. And my question is that not what Defence Work Formation must do?
No, here we are talking about first and second line capability to service our medical equipment.
Okay.
You understand?
Yeah.
However,
So in
let
other words,
me,
it's more specialized. It's more specialized than
It's-
what Defence Works can provide.
it is to a certain extent. At the moment, the Defence Works Formation, in terms of the resources they have, they will not be able to even provide us plumbing, fixing the boiler machine. So if we are funded, we will be able to staff our own artisans that will do this job. However, if Defence Works Formation does have the resources, then we will only need medical technologies to be able for them to be able to manage our medical equipment. Currently, the Defence Works Formation cannot do that. And as we said earlier, at one military hospital, this has been implemented. They are able to fix a pipe, they are able to unblock the drain, they are able to fix the boilers when it needs to. So that one is working at one mill. And we're saying if we are funded, we can establish this and be able to attend to our hospital and base hospitals from that 1,631 posts that we require. And then slide 19, you questioned the issue of medical inflation. Current CPI, I think, is at about 6 point something, if I'm not mistaken.
Yeah, correct.
However, medical inflation is running at around 12%.
12%. Okay.
Yes.
That's very important. That's very important because every time that you do not get
Mr.
at
Marais,
least
sorry,
12%,
Mr. Marais,
then you're actually
please,
moving
please.
backwards.
Mr. Marais, please, let them ask your question, let them answer your questions. If at the end you are not satisfied, you can make a follow-up question. So that
Chairperson, point of
avoid the
order, Chair.
dialogue. To
Point
avoid
of
dialogue,
order,
I will
Chair.
call you.
Noted.
Yes. All right.
Okay.
Point
You
of
may
order,
continue,
Chair.
General. Yes, General. Yes, Honorable Matsomai.
I said this is the new thing that is happening in our community. When somebody have raised the question, and after
Chairperson, I can't hear
that,
anything.
when the general come in and make like we are in a courtroom, I mean, this is a dialogue.
Okay,
If
no,
we are
that,
going to get the
so
follow-up,
Motsomai, the point is noted.
to ask some questions.
The point is noted, General. Sorry, Motomai. All right, thank you very much. Over to you, General.
How we are going to ask questions?
I think his line is bad.
Because
and
I said if somebody
sorry,
is denying
Motomai,
what is happening, questions. If there's somebody who down
no,
and prove what.
sorry, he will not hear me
Chair?
because his line is not stable. Can you switch him off, please? His line is not stable. He's not going to hear me. I've already said yes. Hello?
Mine is all
Mr.
right.
Motomai?
I was muted.
No. Listen to this. I've actually asked them to switch off your mic so that you can hear me. Yes, the point I was actually making, you've made your point, Mr. Motomai. Let us allow the general to to continue with answering the questions. Thank you very much. Over to you, General.
Thank you, Chairperson. And then, Mr. Murray, you asked the issue, we didn't talk about the ramp and refurbishment. Yes, we didn't, because that project is at the moment under Defence Works Formation and Chief Log. So only thing I can say to you is that at the moment, there is nothing happening in that front. The issue of the Hawks, you are talking about the so-called fraud and corruption that happened at 1 Mill. You will, I'm sure the report by the Abacus forensic auditors was presented to this committee, and it was indicated that since the members that were fingered in that forensic audit are either no more in the SAMS, retired, or they've passed on. Now, the matter, in order to pursue those no more in the employ of the defense, was, as far as my knowledge in this regard, the matter referred to the SIU. So I would not be able to comment about that. And then the issue of the Deputy Surgeon General, the only thing I can say to you is he's still not back at work. And then the issue of medical costs with regards to outsourcing, the military veterans. Yes, you were right. The military veterans have got their own funding and they get services from the SAMS, which we must be reimbursed. And in the presentation, you will see that that reimbursement is not happening as regularly as it should. With regards to the retired, these are the VPA members. There is a fund that is supposed to cover them. However, that fund was established with the understanding that the SAMS will provide 100% service to them. They will not have to go to the private sector. But due to the inability of the SAMS, specifically the hospitals, to provide the necessary service, that fund now is referring their dependents, their clients to the private sector. And as a result of that, there is some cost on the SAMS because services that were supposed to be provided for by the SAMS, we have to pay from the budget of the SAMS to cover that expenditure. Now, the issue of saving members, they are supposed to be given 100% care. As we indicated in our presentation earlier, that the state has contracted with these members that they will get full medical care at state cost. So they are supposed to get that. And that's why when we cannot give the services to them, we refer them where they can get the services. The impact on the SAMS, obviously, it's eating on our operational budget. General Langa indicated that this outsourcing, the budget that we're using for outsourcing, as I'm speaking to you now, the outsourcing budget for 1 Mill has been depleted. We are in the first quarter of the year. And then you indicated the alternative of if completely we do not have the hospitals, what will be the alternative with regards to the provincial? Let me state this to the members of the committee that the SAMS is regarded by the National Department of Health and by the provinces to be a private medical funder. So when we send our patients to provincial hospital, we get charged private fees. Now, I think it's Mr. Mutsamai who indicated that the public hospitals are in a state that you will not want to go. So our position is, why should we go and pay private fees in a public hospital when we will not get the services that will be equivalent to what they will get to the private sector? And that's why we refer them to the private sector. So there's no difference. If we send our people to the public hospitals, we will pay a private fee. The issue of the approved strength, I think we have spoken about that. The corruption on the ambulance services, yes, indeed. There are service providers that due to the whistleblower, we managed to get them to admit their corruption. I'm not going to mention the name of the service providers. They have an agreement with the credit department within the Department of Defense to pay back the money. The same is happening with the VPA fund. They are paying back the money. However, General Langa did indicate measures that were putting in place in order to avoid being overcharged, as well as to be able to manage ambulance services if we outsource. That is what we call managed healthcare, where if we outsource a patient to a particular ambulance, in this regard, we will buy an application, an IT application that will be able to assist us using GPS to track an ambulance from a particular place where they've picked up a patient to the nearest hospital in terms of the charges that they're supposed to. What was happening with the corruption of the ambulance service that you spoke about? They would pick up a patient from a distance of about 10 kilometers to the nearest military hospital. And then to travel that distance, since they charge in terms of the hours that they spend, as well as the capacity of the ambulance, whether it's an ICU ambulance or an ordinary ambulance. So the corruption that was happening was that they would pick up a patient, instead of arriving to the nearest military hospital within 30 minutes, they claim that they arrived, they traveled 5 hours. But clearly that cannot be true. And then for a patient who was walking, they would claim ICU ambulance. So that corruption with the intervention measures that we're putting in place will be able to minimize. Then Mr. Ryder, you wanted to know about beds availability. When our hospitals are fully functional, one military hospital is supposed to have about 500 beds when it's fully functional. 2 military hospitals is supposed to have about 270 beds when fully functional. And 3 military hospitals to have about 145. Now, 1 military hospital due to refurbishment, the bed capacity has been cut down to about 250. With 2 military hospitals, at the moment, those 260 beds are available. However, the challenge is staffing. We are unable to utilize all those beds. The same with 3 military hospitals, due to lack of the healthcare professionals, we are unable to utilize all those beds. So all in all, when we're fully functional, the bed capacity of the military hospital, I'm talking only of the 3 military hospitals, I'm not including the base hospitals. It's supposed to be 865. Now, with regards to the cuts that I've indicated to you, we're talking about 500 beds. And for us to be able to have full occupancy in those beds, we need full staffing for us to look after those patients. Then Honorable Mafanya. Yes, I agree with you. The picture is horrible. And indeed, we have been on this for the past 5 years, and there seems to be no solution in this regard. I agree with you. The SAMS, specifically our hospitals, are in ICU. Now, with regards to litigation, you wanted to know if the money that we have indicated, is it money that's spent, owed, or what? The money that we have indicated here is the claims. Let me explain this. If I've got a claim against a health funder, we will put a figure that we will want to be compensated for. But however, once that matter is settled, the figure may be significantly very low. For instance, let's take that one of birth injury, where they're claiming 43 million. Once the matter has been concluded in court, you might find that probably we pay 10 million or even less, because usually that 43 million will be based on what they would expect to spend on the child until the child passes away, depending on the injury that the child has had. So most of the time when we have cases like this, we will offer that we will look after this patient ourselves, and that will cut out the amount that we'll need to pay. And maybe we will just pay a small figure with regards to probably the pain and suffering that the parents may have. So the figures that we've put here, it's claimed, not paid or owed. At the end of the court case, it may not be that. Now, you indicated the issue of staffing and productivity. We feel that the staffing that we have within our facilities are utilized fully and productively. Bear in mind, in our presentation with regards to our mandate, what we are supposed to provide, our primary mandate actually is operational support. In other words, we must support the troops when they are in operations. We must support the troops when they are in Corona. We must support the troops when they are doing exercises as part of training. So the productivity of a healthcare professional in the sense cannot be compared to the productivity of a healthcare practitioner in Steve Biko, for instance, if you compare to 1 mil. That doctor may be required to deploy. And when that person is deployed, and we do not have another person to replace them, that's where you'll find that we will have to utilize overtime. That's why Treasury came to us and say, we are abusing overtime. General Langa indicated that due to our commitments and the staffing level, we are unable to provide shift system in order to avoid paying overtime. And bear in mind, a shift system will probably need 4 times the staffing. That will cost the fiscus much more than paying overtime. So in answer to your question about staffing, I'm saying to you, I feel our members are being used productively, and we can prove that. Let me go back. I've spoken about, Honorable Mafanya, I did respond to you. And then there was a comment by Honorable Mutsamai. Yes, I'm glad you didn't get the accident at 1 mil. I was a little bit scared when you said you get accident at 1 mil. So I'm glad that did not happen at 1 mil. However, we will always take care of our clients when we can. You mostly what you were indicating was comments, but let me take one area that you raised, the issue that if you phone one military hospital after hours, you will not be answered. It is true. You will not be answered because we stopped paying overtime for administrative staff, especially to men the exchange room, telephone exchange room. Unlike in Steve Biko or any other, they work 24 hours. In our case, we were told you're abusing overtime, don't pay them. So they don't work after hours. And then again, the challenge that we have with Treasury, they feel we're abusing overtime because we pay overtime to cleaners, we pay overtime to food handlers. On the basis that if you're gonna open it 24 hours, you will want the wards to be always clean. Patients must always eat. So therefore, one military hospital will pay overtime to support personnel, again, on the basis that we do not have enough to work on a shift system to avoid overtime. And I've said, if you have 2 persons that you can cover the 24 hours by paying overtime, if you want to stop that, you probably will need 6 individuals to cover that shift system, considering leave and absent from leave. So you probably will have to spend more to avoid overtime. Unfortunately, that we did not agree with Treasury, and that's why they took the money from overtime and reallocated it to equipment, which we appreciate. However, it compromises another side of our service provision. So I think I've responded to the 4 members that commented. If I've left something, my colleagues, if you can add, but I think I've responded to all the issues raised. Chairperson, thank you.
Colleagues, then take the first round in that order that I saw it. Let me go to it. It was Thabo, Mothapo, Bukas, and Bekle. Thabo, Mothapo, Bukas, and
Start
Bekle.
with me, Chair.
Starting with Mothapo. Okay, Mothapo. Mothapo? I can't hear you, Mothapo. Thabo, let me start with you. Honorable Muhle.
Thank you very much, Chair, and good evening. I might have missed some of the responses due to connectivity issues. The line was breaking, so you'll pardon me, Chair. If I'm repeating, you'll just indicate. My first point of interest that I would love the General to expand on, it's on their plans in terms of the military health systems. That what is their plan in terms of ensuring that the pride of the military health is restored, and how are they going to ensure that as and when they restore that pride, they ensure that they put in place medical technologies that are advanced. I'm saying this because, Chair, for me, it doesn't make sense that we have a facility like facilities like 1 mil, 2 mil, and 3 mil, which must be far advanced in terms of medical technologies, equipments, far above what the private sector is doing. These technologies must be piloted through military health systems, even before the private sector can lay their hand on those technologies. What went wrong? What happened? And what is their plan to turn around the situation so that they bring back the pride of the military health system or hospitals to be advanced as we know them to be advanced? And I know that there was an attempt to, for a lack of a better word, to wave away the RAM project, but I don't think it's correct for the general to simply waive it away because it's under works formation or public works for that matter. My understanding is that, Chair, they are the end users of these services. This is where the buck stops with them because they are the end users. They are the one who made these requirements, and through processes that is not under them, we ended up having this project. And it's not only 1 meal, even 2 meal. There was a project there, and we once went there for a visit, and we got to understand that some of the challenges that hindered the project was as a result of SAMS distancing itself from the project that they are the end users of. Where we found out that medical technology specialists were not involved in the project. Therefore, at the tail end of the project, it's only then that the end user begin to complain and say, this is not available, this is not there, this and that will not be able to fit here and there. I mean, you can't sleep throughout the project, and at the end you become a complainant of the project that you must be able, you must by virtue of you being the end user, be part of the process to ensure that by the time they hand it over to you, you have played a role, and whatever that will be handed to you, it's exactly in the manner that you specified it at an initial stage. So I don't think it's correct for the general to waive it away. To a larger extent, they must be part. They should. It is expected that they should be part of the process of this project, and therefore they should be in a position to give us the status insofar as this project projects are concerned. And I think the issue of overtime that I wanted to talk to has been responded to. And I think I'll pause there, Chair. Other issues, I think they've been covered through the first round that was taken. Thank you, Chair.
Thank you very much, Ms. Mutapo.
Thank you very much, Chairperson. Chairperson, my apologies. We are load-shedded here. I've got 2 questions here, Chairperson. Let me start by thanking SAMS, South African Military Health Services, for the presentation and for the well spelled out concluding remarks, can I say also recommendations. My concern is around the Department of Military Veterans debt, Chairperson. I would like to know the age of that debt and what measures did SAMS put in place in order to ensure that that debt doesn't prescribe. A debt of about 800 million, subject to correction, Chairperson. And then secondly is the issue of litigation. Honorable Mutsamai or Mafanya did make mention of it, and other speakers, for medical and malpractice, medical malpractice and negligence. What I would like to know, the amounts which appear here, do they also cover legal fees, or are they doing it on their own? Or are they also briefing councils in this regard? Because what I see here, it appears as if it is only for claims for medical negligence, but they can just clarify this issue. I've got a very serious concern, Chair, because it appears if our hospitals which used to be prestigious, are not accredited because we are told there is a threat to discredit, to not continue with accreditation of this hospital. This will be a very serious cause for concern for us, because how then will our soldiers, who are supposed to protect the sovereignty and the integrity of our country, perform their work? Because they are supposed to be very healthy at all times. So I'm really very, very, very much concerned. And I also echo the sentiments echoed by the speakers before me, Chairperson. Thank you.
Thank you very much, Ms. Machako. Ms. Bukas.
Thank you, Honorable Chair, and also thank you, General Langa, for the presentation. I just want also to proceed on the one of the claims, Chair. In the presentation, Chair, it seems like most of the claims are valid. Now, I want to know, did they ever use that analysis to motivate more funding? Because the money that they must pay for claims, if we look for the reasons of the claims, the money they must use to pay for the claims could be used to upgrade facilities and appoint a specialist in medicine. I want to know, do the general agree with me on that? And then also I want to know, what is the time frames for the investigations of those claims? Chair?
Which claims? So, which claims are you referring to?
The legal claims, Chair, against
okay.
yeah. And then also the percentage of claims that was successful. Was all the claims successful, or what? What is the percentage of the claims that was successful? Then, Chair, over the past 5 years.
So in which financial year? I think you need to confine it to a financial year, Ms. Bickers.
Yeah.
Or you want to go back in time? I don't think, maybe in the last year
maybe
or
I
2 years.
missed it. Maybe I missed it, Chair, but did they define in the presentation, or is it just in this financial year, the claims that they spoke about?
Okay. They will determine how far they go, depending on the information they have in their position. Okay, that's fine. Let's leave it at that for now.
Okay. Sure. Then over the past 5 years, there was an increase in outsourcing and medicine buyouts by the private sector. I want to know, what was the impact of this on the budget? Whilst they need skills and a well-resourced HR, is it not better to either go the route of advertisements and recruitment as to outsource? Then lastly, Chair, the health facilities need maintenance and repairs, and SAMS already lost a number of specialists due to the lack of compliance of the medical facilities and equipment. And now they must repair the equipment and also appoint new specialists. Are there measures that they are using to monitor compliance, for example, to the facilities and equipment? And is there, for example, someone or a unit or a plan with time frames to prevent it to happen in future? Thank you, Chair.
Thank you very much, Ms. Pickles. Ms. Petley.
Thank you very much, Chair, and good evening to everyone. Chairperson, let me just talk to this issue of overtime, as majority or many of the comments and questions are raised by my colleagues. This question of overtime that is not attached to the shifting becomes a question of a concern, because we do have a legislation in this country that regulates overtime payments. That's one thing that I don't get it clear, as in when General and his team, they're talking to it, because indeed, when you're working in this in the hospitals and you work overtime, it's going to be difficult because you get tired more than the patient itself. Does that give them a good idea if they are not giving this a committee to say one amongst their projection is to have either a 3-shift, not even a 2-shift, because we're talking about something that Comrade Tawo has spoken, the plight of the sovereignty of this country in terms of this aspect. The second aspect is that in relation to the staff complement that they want to bring in, I'm not too sure how do they project that particular budget, because anyone who's coming in a new employment cannot outrightly go up, particularly on the administration level. We should start somewhere else. And we cannot start payment in a retrospective of equity at the same time, so that we satisfy everyone. That's when they recruit, what are they using? What is their criteria in terms of recruitment if they want to recruit a new staff members in that regard? And the other thing that I heard them talking to a chairperson is on the question of lack of leadership. I did not understand that particular comment, and I can't recall who said that from the colleagues of the SG themselves. But their budget really is a retrospective, because it's not talking of the projection as to from all these hospitals, which ones are more key? Because when you budget in regards to this type of facilities, they need to share the timelines. If you start by 3 this year, the following year you start by, it's going to be a lifeline of rotation in terms of budgetary processes to ensure that our system, our facilities does not get deteriorated in between. The threat of being disqualified, or the threat that is saying we're not in line with the WHO, then it's something that can be kept off. But if the projection of the plan is not upfront to say from 9 or 10 or 20, for an example, these are the key 5 that we're going to start with in regards to new systems, in regards to employment, in regards to whatever that they want to bring it in, is what we're going to do. The last issue, Chairperson, that I'm concerned of is outsourcing. I don't hear SG together with his team telling us as to how much have they saved from all the outsources that they have made, how much they have saved, and what have they utilized that money on, and what was the issue in why are they still is it still prudent for them to work with the outsourcing? Because I know the outsource person, the outsource departments, I can tell you, the service provider that you outsource to will not give you 100% a service that we expected from, and that's where you're going to get those litigations. That's the dangerous part when you outsource a particular department to somebody else. Does not care because it's not paying those people enough. Those people will do what earlier on was said, that they were exaggerating the kilometers in terms of traveling and hours and so forth. So can they help us in all those that were raised? I think I must just stop there because majority of the questions were covered, Chair. Thank you so much.
Thank you very much, Mrs. Mthembu.
Thank you very much, Honorable Chair, and good evening to all members on the platform. Honorable Chair, my question is attached on one asked by Honorable Petle for the overtime. Mine is that generally have mentioned that during the late hours, phones are not answered. I just want to find out if there is a crisis or there is an urgent case that need to be taken care of. How do they manage in that situation? Because anything can happen during the late hours. Thank you very much, Honorable Chair. Other questions that I was intending to ask, I'm covered by my colleagues. Thank you.
Thank you very much, Ms. Mthembu. Now, thanks. Let me invite the General to field the answers. Over to you, General.
Thank you, Chairperson. We'll start with Honorable Mutle. You wanted to know in terms of when we buy technology, whether we've got plans to have the right technologists to look after this technology. Yes, it's not a straightforward answer that I will give you. With advancement with technology, and you will know that technology advances quite rapidly. Now, we cannot compare technology of today to the technology of 20 years ago, where you could buy an equipment and be able to utilize your own technologies to maintain that. The reason being that most of the medical equipment needs to be certified to be able to perform the job that they are supposed to perform on a patient without posing any harm towards that patient. So it's let me give you an example. If you buy a Mercedes-Benz, they will recommend to you that we recommend that you buy the maintenance plan of maintaining Mercedes. It's your choice. You can decide, no, I don't want this, and then you go and service the Mercedes-Benz from somebody else. And you take full responsibility for that. So in the case of medical technology equipment, most of the time, it must be serviced by the own equipment manufacturers. For them to be able to say, we have serviced it to the level that we can certify that it can be used on human beings. For instance, I'll give you an example. If we are to buy an X-ray machine, that X-ray machine will not be utilized until the Radiology Council comes and certifies that it is right to be utilized. So what I'm trying to say to Honorable Muntle is that in this day and age, when you buy a medical equipment, if you own that equipment for a year or two, you'll find that next year there is a new equipment. And usually the manufacturers will tell you, we do not have the space to fix that machine. You need to buy a new one. So health is not cheap, it's expensive. So what I'm trying to say to Honorable Muntle is that whatever equipment we buy, it will need to be serviced by the accredited service providers for it to be certified to be compliant. So statutory compliant cannot be outsourced, unfortunately. Now, you indicated that we cannot just push aside the issue of ramp and refurbishment as the same we are the end users. Yes, indeed, we are. However, we know how government functions. So when I say this matter, I cannot respond to, and I did say that there is nothing happening at the moment because there are still contractual issues that are being fought by the people who are managing the ramp. The moment they tell us now we can go, then we will get involved to make sure that whatever is done in that hospital will be what we will certify at the end of the day, because we are the people that must certify that this is the equipment that we want to be installed. This is how the theater must be built. There are medical technologies who do that. I'm not so sure if when you visited One Mill and they gave a presentation, they would have told you as part of the contractors, there were medical technologists. These technologies were working with our specialists in order to find out from them what type of equipment they want. What do they want to do with this equipment? So we will get involved once the refurbishment is started. At the moment, we're not involved with the contractual dispute because we were never part of those contractual disputes in the first place. Now, the issue of overtime. You know, I tried to explain the need for overtime. And then that may also be explained with the staffing levels that we have. Now, let me indicate this. In order for us to fulfill our mandate, with each and every unit that we must utilize to support our mandate fully. Let's take, for instance, a battalion that deploys in an environment. It will be supported by a unit of the SAMs. Now, when you do that with the army, when they deploy, they've got 4 units. One is in deployment, one is in training, and one is ready for deployment. The other one is resting. So in other words, they've got 4 to be able to do that. In our case, due to staffing, we don't have. So you'll find that when we take out a doctor from the hospital to go and deploy, we've got nobody to cover that doctor there. So in other words, for us to cover 24 hours in the hospitals, by the way, we need to get them to work overtime. This is with healthcare professionals. I even mentioned earlier that due to staffing, we even have to pay overtime to support personnel. I gave the example of a cleaner at one military hospital. So if you've got 4 cleaners and you're doing shift on those 4 cleaners, they need to have other cleaners in reserve. So in other words, if we're doing a shift of 6 hours, we need 4 cleaners to do the shift of, I'm exaggerating here. Most of the time shifts, it's 8 hours. So that means you will need 3. You need other 3 to be on standby for them. We must count in leave and everything like that. Now, instead of paying one person and then you cover for them to work more hours through overtime, you will end up paying probably a salary of 9 people to cover one shift. So the people need to realize the expenses here. You take away something, you must give away something. So the issue of overtime is not only yourself, members of this committee, that are worried about. We are worried about, and that's why Treasury took money away to say go and buy ambulances, because you are abusing overtime. They say we're abusing overtime because we pay cleaners, we pay food handlers, we pay people who work in the sterilization room overtime because we don't have enough numbers for them to work in shift. So overtime, it's one way of ensuring that we're able to continue to provide 24-hour service at probably a minimum cost than pay compensation of salaries for 9 people instead of maybe 4. Now, to Honorable Mutapo, the issue of the military veterans, we indicated that the money owed to us is 174 million, just to clarify. And this is for the previous financial year. Now, in order to avoid it prescribing, we ensure that by law, if you remind somebody that they owe you and they acknowledge it, that debt does not expire. It's only if you did not inform the person that they owe you that that debt will expire. And that has been done through our creditors at finance. They write the military veterans that you owe us. The good thing is that there was an arrangement here with the Treasury that when that money comes back, it does not go to the B7 account, that is back to Treasury, it comes back to us. Now you can imagine what we can do with that 174 million if we're to be given on a yearly basis. But it's not happening as it's supposed to. When we speak of litigation, you wanted to know if that includes legal fees. The Department of Defense does have a legal department within, lawyers who work for us and defend us when the needs happen. But then we've got a challenge that our advocates may not work in the civilian environment. So most of the time, our own lawyers will prepare the case and then prepare it for the advocates. We use state advocate. So we don't go to the private sector, we use the state advocate. So we did not, in those figures that we gave you there, these are the amounts claimed for the past financial year. With regards to what percentage, I don't know if that was yourself, but I think there was somebody who wanted to know the percentage of cases lost. I think it's Honorable Bucas. I will answer that as we go. You also, Honorable Mutapo, wanted to know about the accreditation and us losing the prestigious position of the military hospitals. Yes. That prestigious tag of the military hospital, specifically one military hospital, has been lost. You will remember, we used to have heads of state that will come all the way from Central Africa to South Africa for treatment. But unfortunately, due to the state that is in, we lost the level 4 accreditation by the UN. We are no more. Now, in terms of training, there are certain criteria that a training institution must meet for it to be accredited by the statutory body that wants us to train. It's not only doctors, it's nurses, it's doctors, it's radiologists, it's pharmacists, and all. They are there for training. The advantage of this is that you get students who are in training with their supervisors, and these people add as a force multiplier for the military. If we are a teaching hospital, we get specialists rotated at one meal to teach the students while they treat our patients. But because we have lost this accreditation, therefore, the little bit of a healthcare professional that we used to get from the universities, we have lost that. And then Honorable Bucas, yeah, you wanted to know the claims. Yeah, you wanted to know the analysis for whether we did the analysis with regards to how much we are paying on claims and whether that money that we lost could be utilized for something else beneficial to members of the defense force. Indeed, if we do not have claims, we would not have to pay these claims from the litigants. We gave reasons why some of these claims comes, but again, our population has become a very litigious society. They will try and claim medical negligence on almost anything that they can lay their hands on to make money. It has become a money-making scheme. However, I'm not defending the fact that there are certain areas where indeed we may have been at fault. However, in terms of the rate of success, I do not have the figures here, but our legal people will be able to provide that, and then we can provide it to members of the committee if required. And then you indicated, what are we doing to recruit? We do advertise posts for recruitment. And to be honest with you, we do get people applying and be employed. But they don't stay because they come in and they realize, oh, how can I work in an environment where the equipment is about 20-year-old, and then if I use this equipment, I may make a mistake and then end up being litigated. They leave. We don't keep them. So what we are asking here for us to be given, it will help us to be able to minimize most of these impacts. So if we have facilities that are functional with up-to-date medical equipment, well, you know, most of the people don't leave us because they want more money. They leave us because we don't have the tools of trade, or we employ them and they end up just sitting and do nothing, and therefore they leave. You will remember, I think it was about 6 years ago, at once we lost in a pediatric ward about 6 specialists who left on the basis that when they work in our pediatric ICU, they risk their careers because the equipment that is there does not guarantee that they will save the kids that are in their care. So we do recruit them and then they leave us. So the requirements that we put here, we do believe that it will help us to mitigate in terms of losing professionals or even getting medical claims against us. I think I've responded to each one of your questions. Then Honorable Petle, the issue of overtime, I've discussed this quite often. I guess it's clear. There are regulations that govern overtime. However, Treasury looked at this and say, why are you paying overtime to cleaners and food handlers? I've already explained what, but we did not agree with Treasury, so they took the money away. And at the moment, the issue, I think there was somebody who questioned, wanted to know about, what happens then when there is an emergency? When the switchboard knocks off at 4, they transfer the phones to casualty. So when you phone the switchboard, that phone will be rerouted to Treasury, to casualty. Now you can understand, there could be a lot of people phoning that one phone in casualty. Most of the time you'll find that it's engaged. Or sometimes because the nurses, the people who must respond to this call, it's nurses and doctors. Sometimes you might find that when you phone, they're busy with a patient and there may not be somebody extra to go and answer the phone. So these are the challenges. However, it does not mean you cannot access the hospital. So the phone call that you go to the switchboard has been rerouted to casualty for them to be able to respond. Again, Honorable Mthembu, that was the issue of what do we do after hours. And the overtime, I think I've dwelt on that for quite some time. Honorable Chair, I think I've attempted to, if I've missed others, my colleagues, if you can assist me, but I think I've attempted to respond to all the comments and questions. Thank you.
Thank you very much, colleagues. The Chief Director, Military Health Force Preparation, Major Smelane, I can see your hand is up. I think you want to add one or two things. Am I invited to do so?
Yes, Chairperson. There was a question about recruitment. What I need to add is that we recruit professionals mostly for healthcare purposes. And those do not start from the base in terms of earning. There are experienced professionals that would be working either in private or in the public sector, but Department of Health. So those cannot be compared to people that have just qualified. So I just needed to explain that. I cannot remember who asked that question about recruiting and then the level of salary being at what level of the salary. It depends on the professional that we're recruiting and the expertise that is needed at that time. If we need a specialist, we'll recruit a specialist, and that specialist will be remunerated according to the experience that that specialist come with. I just needed to add that. Thank you very much.
Honorable Chair, if I may add, I think he reminded me of the question again, maybe to add on what General Smelane have said, if you allow me, Chair.
Okay, yes, General.
Yes, there was a question in terms of the figures, the money that we needed for the additional staff in terms of how did we reach that stage. We use the current notches at the highest level of that particular post. So we use this year's salary level at the highest level of that particular post. Obviously, with the years, with inflation and the compensation of employee increases, that figure will increase. That's why General Langa indicated that it's not a once-off. It will be for forever, as long as we employ that person. Thank you, Chair.
Thank you very much. Right. It's Mthembu, is this your legacy hand? It's a fresh hand.
No, it's a old one, Chair.
Okay, thank you very much. Mr. Rader, is this a legacy hand or a fresh hand?
Just, if I may just say that I wasn't fully satisfied with the question the answer that I got to my question. I understand that it will probably do better as a written question. So I'm going to...
Maybe can you repeat the question?
It was just relating to the occupancy rates of the beds, the number of beds, and then juxtaposing that with the number of staff per bed needed. But I think it'll work better as a written question, Chair. So I just want to say I will be putting that in writing through the normal channels, but the General shouldn't be surprised when he sees it at his desk. He mustn't think he answered it fully. I'm looking for a little bit more detail. Thank you, Chair.
Yes, no. Thank you very much. I noticed that the question wasn't adequately dealt with. For example, the bed capacity was given to be 823. If you take all three hospitals combined, and that due to challenges with the RAMP program in the military hospital, that 500 is down to 250, and that in military hospital, two military hospital, that 207 is also down, as well as the third military hospital is also down, giving the total of 500 occupancy rate. Maybe let me just come back to you. Are these the available beds or this 500 or is the occupancy rate currently?
Chairperson, that is the available bed.
Oh,
and available beds, yes. I would also want to
but the question was occupancy. What to do? Yes, you have 500 available, but what would you regard as on average your occupancy rate?
Okay, maybe to respond, let's take the example of one military hospital. That 250 at any one point, averagely, the occupancy will be about 51%. Now, let me qualify that. If you look at a military hospital and you compare it to Steve Biko, you might say you're working at half. However, military hospitals are supposed to be a strategic reserve of the country in case there is any disaster. You will realize there was a time when there was a train accident in somewhere here in Pretoria, and we admitted most of the casualties to one military hospital because that reserve was available. So when you pay health capability in the military, you must also consider that it's an insurance. You may not use it. However, it's on standby when the country needs it. So we will provide the response in writing when Honorable is Honorable Rader.
Yes.
Yeah.
You see, I understand this question, General. He's trying to juxtapose it with the personnel shortage that you have spoken about. And so what in general terms, what would you regard as an occupancy rate. Yes, I hear you that in respect of military hospital is about over 51%, thereabout. Generally for all three, what would be the combined, what would be the occupancy rate?
Chair, I would not want to commit myself in that because I do not have the figures. I would actually take the opportunity for us to respond, sorry, in writing.
Okay. No.
However, again, consider the issue of outsourcing, that not all the patients that are supposed to be at 1 mil are at 1 mil at that stage. They are outsourced on the basis that we may not have the personnel that can look after those patients, or we do not have the right equipment to look after those patients, and therefore they are outsourced. So when I'm talking about, these are the patients that are admitted in the military hospital, which we can look after. However, we will respond in writing, Chair.
Okay, please do, because that has implications on the issue of overtime as well, that you have spoken about. All right, no, it's fine. We will come back to you in writing on that one. Honorable Thabo commented on the turnaround plan in view of all these challenges. In other words, he is actually asking if you do have a plan that ideally, everything being equal, this is the plan for the hospital. Sorry, for SAMS, you know, the 3 hospitals, the 5 what you call clinics, as well as the what you call this, the sick bays at local level, the equipment you need and all that. Do you have that information? You know, that is accumulated. It just composite, you know, in a form of a plan, and which then says that if this plan, this is what is available and funded, and therefore leaves us with this that is unfunded and unavailable.
Yeah, Honorable
I think
Chair.
I was talking to that. Yes. Yes, General.
Yes, we do have the plan. Actually, we presented here today the plan that we have, and we can provide it if there is a need. We presented the plan. We specifically even mentioned, for this we need so much money. For this we need so much money. For personnel, we indicated we need so much and so much money. So we do have the plan. We are not just sucking these figures from the air. Thank you, sir.
Okay. All right. And then there was also a question on medical legal claims. I think the question was, does this medical legal claim cover medical negligence done by the facilities to which you have outsourced the patients, or it only refers to what you call medical negligence that took place in your own facilities only?
Yeah, to respond, Chair, the claims that we're talking about here are the claims that arose in our facility. When a claimant puts up a claim, they will list which people they're claiming against. So if the person was looked, say, for instance, at Unitas, and there was a perceived malpractice, Unitas will be listed as one of the respondent, as well as that doctor that looked after that patient as a respondent. In our case, it may be, yeah, you didn't look after me. If you had the resources, I would not have gone to that hospital. Some of the claims could be those. But the ones that we gave you here, these are what happened within our facilities by our own people. Thank you, sir.
Yes, well, thank you very much. And then lastly, you said that the figure you showed us, I thought this was accumulative figure, but in your response, you were suggesting that is the figure for last year, for one financial year correctly. I mean, only. Is my understanding correct?
Chair, now, in the presentation that we made, we said these are pending court cases as on the 31st of March, 2023. So that it's
accumulatively, General.
Yes, yes.
Okay.
So these are the numbers, that 32 is accumulative.
Okay, no, that is fine. Those were just a clarity on the questions that the colleagues have asked. And I think we can, colleagues, end the discussion on the following, which we'll have to make a follow-up on. I think the general says that the overtime, the money that they've been using for overtime has been reduced, and reallocated as a ring-fence budget or allocation for ambulances and equipment. So it therefore has serious implication on the functionality of the hospital. He says they had to use overtime because they've had to stretch the capacity of the existing personnel to then be able to provide the service that they've been providing to their clients. Now, if you don't have the personnel and you don't have the money to pay overtime, you could use to stretch out to extend the hours of the existing employees, then that has serious, heavy impact on the services they are rendering. But it doesn't tell us, and the extent to which the service will be compromised as a result of this. And Mrs. Motapo is saying that if you don't have, no, I think it was Mrs. Petley, he asked as to whether was there ever a limit as to how many hours a person works as overtime, and they give you that they were actually were being extended across the shifts system. And she was even suggesting that on its own may render the effectiveness of the medical officer, may actually weaken the effectiveness of the medical officer, to a point I'm now adding that may in fact endanger the patient or lead to further medical medical legal claims because the medical officer is tired. I think she used the word, that person would get tired when he or she attends to the patient, and giving rise to medical negligence, which then gives rise to further medical legal claims. I think so. that's the danger. That's the risk that is attendant to a situation where you don't have sufficient numbers of people to provide a service to the patients, as it were. So I don't know if we need to do a follow-up on this, because we can't just leave it open-ended, because it provides a real risk to both the patients as well as the government in terms of medical legal claims. So we may need to do a follow-up on that one. And yes, I think those are, oh, okay. And as well as the issue of occupancy, bed occupancy, I think we may have to come back on that one. Yes, we'll do it in writing. We'll put a question in black and white and ask the department to come back to us. But we will still need to do a bit of a follow-up on it. And then thirdly, the money owed by the military veterans, the deputy minister is in the meeting. I'm sure that can be trashed out, because it's only lost, inverted commas, or not available for utilization by SAMS. It's there in the Department for Military Veterans. We know that in other years, the money had to be sent back to Treasury, surrendered back to Treasury because you could not spend it, when in actual fact, you have, DMV has accumulated claims that remained unsettled. And so, I don't know, I think we need to have a close follow-up on that one, so that we facilitate a process where on verifiable or verified claims, the money is transferred from the DMV to the department without any further delay. But I'm sure the DM will comment on that one. And then the third thing that we need to come back on, it's when the the public hospitals, our own hospitals, when they treat patients referred to them by our own, by the military hospitals, they charge them private hospital fees. When service is not at that level, it's just they're rendering what you call public, a service. I don't know how that can be mitigated, because if that was mitigated and that they are not charged the same fees that they get charged when they send patients to private hospitals, that on its own will actually mitigate the expenditure that this department, the service to put up with. And on the ambulances that are facing some ambulances that ambulance operators that are fleecing the department, charging for kilometers not traveled, and so on. I think that we can leave it to the department to deal with. I'm sure they will find a way of implementing measures to mitigate against that. And I thought perhaps those are the issues that I think we need to make a follow-up on. And then the last point is the point that Ms. Bucas raised, the loss that we are losing specialists because of poor equipment. And so we need to try and, make a follow-up on this one. What are these urgent items that equipment. We need to do prioritization. I think that's a point. This is, I can't remember who raised it, that when in situations like this, and you can't just be general on all three hospitals and say the amount available is going to be distributed amongst all of them. You have to prioritize and say, in this year, we are going to resource this hospital up to we are satisfied that it's adequately resourced, and then use the remaining money to support the second one and so on and so forth. So I think also as we spend the allocation that has been made available, we need just to pay a bit of attention that we ensuring that the amount allocated it's used optimally. How they use optimally, but we leave it to the department. They will come back to us and justify that they found a better way of using it, so that we don't lose more specialists. Instead, at least there's one hospital that's able to attract them back and to it, so that prestige we once had, at least it's slowly revert back to the state, even if it means in one hospital we restore it. So I would want just to say these are the issues that I think will have to be followed up on. Unless colleagues are missing one or two, I would allow just one hand just to talk to that before we ask the DM to close. And then maybe the last point is the contractors that were involved with the military hospitals. It's now many years since the ABOCOS, I think 2 years since the ABOCOS did their investigation into the hospital. And the recommendation was very clear: sever the relations with the ties with the contractors, because they failed to deliver on their thing. And the contractors indeed are no longer doing the work, but the department can move in and take over and engage other contractors, because the contractors that they were doing work there, they have not completely pulled out of the contract to then pave the way for new contractors to be appointed. So in other words, there's still legal dispute surrounding that thing. I don't know why must it take this long before it is clarified and settled. I don't know if the legal advisor to the minister cannot just help us look by looking at these contractual agreements and why even up to this point we still have not, the department has not been released from the contractual arrangement with those contractors. And because until we have been released, the department is released from the contractual obligation, they can't go ahead upon new contractors and then start doing some work with the legal resources that are available. So I thought I should just raise those matters as requiring further follow-up. Mr.
Chairperson, can I just add to that? Chairperson, can I just add to that point?
Yes, please do.
I think that's a very valid point that you have raised, and I would even suggest and request that they must give us feedback, even if that indicates that the contractors might have a legal case against us or anything that might impede on that. So even if there's a negative to our side, that maybe we have been in default and the contractors basically claim that they are not solely to be blamed for that. That we know about that, so that we actually know where do we stand, and that will also give us an indication of the complexity of this case and how quick this will be resolved. Thank you, Chair.
Thank you very much. Please, I would ask DM to comment on that and check if they cannot engage the legal advisor to the minister to look into this issue for us. We want to pull out of this contract, but it's many years now that we are unable to do so. Why? We don't know, but I think the legal advisor can go into the contract, look at that, and pick up all the issues, including the issues Mr. Mara is talking about, and advise how the department can move forward. There is a state-off very clear, but we can't continue like this, and we can't just leave it at that as the portfolio committee. Not that we are going to do anything, but we need to know why is it difficult for the department to pull out of that contractual arrangement with those contractors for the one military hospital ramp project. All right, having said those things, I don't see any other hand. Colleagues, I'm now asking the DM, any other hand, agent, nothing, DM, I'm now giving it over to you. Over to you, sir.
No, Chair, thank you very much. And to committee members, thank you very much. Chair, the Surgeon General and his team has provided, I think, additional information to what that circulated by way of, their presentation. But they've also provided explanations around the challenges that they have as one of the important arms of service of our defense force. What I can say is that the Joint Standing Committee on Defense is now aware of the state of affairs as far as medical services in support of our troops and the military community, both in service and those who have since left the service. They are at 62% of the formally approved capacity. And what I find striking is that theoretically they are way above. They should be way above the force levels of our Air Force, but in reality, they are far below even the force levels of our Air Force. But it is helpful that the Surgeon General has indicated that they're only not just complaining about the 4,000 plus posts that they are short of. They've even given you a sense of what they believe they would need, not the ideal strength, but what they believe they would need in order to be able to cover all the necessary basic service areas that they must be responsible for. They've given you a sense of that in terms of numbers, figures of the of the personnel they need to employ, but also the budgetary implications of that. What we must, I think, as both the ministry and the oversight, as people given the responsibility to supervise our defense function, what we must appreciate is that SAMS is not where it used to be. SAMS was not just, there to provide services, health services, to look after the health of the force. SAMS was in the cutting edge of research, technology, research within the medical profession in this country. There are projects that SAMS used to run, that in terms of new technologies, you would not find in other areas of the medical profession in this country. So it has lost that place in the development of technology and general know-how in the medical field. It has lost that place. The Surgeon General has just, for instance, indicated that it used to be the practice that heads of states from other countries could easily be referred to one meal for purposes of receiving the best medical attention available. But that is no longer the case. So that's something that we must also take to heart. What I can say is that in the context of the cuts that the Treasury has imposed on our defense force, SAMS seems to be the worst affected, because out of the strength of about 10,000 plus employees, they are standing at 6,000 plus. And they are saying, in order for them to provide the services they are expected to provide, they are relying on the reserve forces. And the clever way we thought we could go about this challenge of a very reduced compensation of employees' budget by cutting down man days. With SAMS, if we're going to cut down those man days on SAMS, then we must appreciate that it's not just a question of reducing the man days. The service is not able to operate. Largely, it will not operate without members that are brought in through call-ups. Because as the Surgeon General has patiently explained, within their formal posts, they do not have the numbers that they need to support the regular force. As things stand, they can't support the regular force without bringing in the reserves. You see, that's where the crisis it's actually demonstrated in a way that we must appreciate. We are unable to support the regular force through the posts that SAMS has. For SAMS to be able to do that, it must bring in the reserves. So the mandates that we were targeting to cut the compensation of employees' budget, we can see, how deep it runs and how deep it goes as far as the South African medical health services are concerned. I thought that's what I should add. The 1 mil hospital renovation project, it's a discussion on its own. And we must give an update about that challenge that SAMS had. But it is, for me, just one very pointed, weakness on our part as DOD, that at times, even with the meager resources that we have, we fail to optimize the opportunity that we are getting out of those limited monies that we get. And I just hope that as far as the SAMS leadership, the command now, will appreciate that there's really no time. There is really no luxury as far as getting the utmost outcome from every little cent that we get from Treasury. If anything, the health services of the South African Defence Force should be appreciating the pressure with which they are executing their functions as far as the way they have used money before. That's what I can add to what members have submitted as observations. As I'm saying, we will still come back on an update report as far as the 1 mil, project is concerned. With that said, Chair, let me step down. Thank you very much.
No, thank you very much, DM, for those remarks. I think, like you have pointed out, the oversight portfolio committee, the oversight committee is now fully aware of the challenges, and that the opportunity of having this as the only item on the agenda or briefing from the department has certainly helped expose or make visible some of the issues that were not so visible to the committee. We are in discussion with Treasury, National Treasury, and we have also escalated the issue of funding in Treasury. We're discussing the capping, the ceiling imposed on the department. That's one, and we've escalated the issue of funding in general to the highest authority in the country, and the feedback is positive. And so it is in that context that we thought we need to sit down with you, get to understand exactly where the challenges are, and how much in actual fact you will need to deal with those challenges, so that in our discussion we are able to make it visible that unless the department or the SAMS, the South African Military Services, is assisted in this way, the services we are rendering, or they are rendering at all these health facilities, will decline to a level where it's no longer worth it to maintain those hospitals. So when you lose a specialist, when you can no longer pay overtime, and so it means that the department will only exist as a body, as a referral body or entity. You look at your clients, you refer them to this and that hospital. In the end, you become an agency on behalf of those private hospital as well as the public hospitals under the Department of Health, instead of providing the service yourself. You only exist to refer people left and right. And then the question is, what then happens becomes of the facilities that we have just revamped, repaired and maintained, and we sustain it at huge cost? What then happens to the personnel that is already in existence? And when it's there, but it can no longer provide full service as it were. So these are the questions that or the issues that we raise with the team. But I agree with the DM that when resources are made available, let's optimize on those resources. Let those people who remain, those officials who are suspended for extended, period, are brought back to active service. Because once they remain on suspension, we pay people to do their work, because they're on suspension with full pay, and you pay other people to act in their position. I'm not saying that it's this entity that is before us that is guilty of that problem, but it's a general problem within the department as a whole, where we pay people who are on extended leave or suspension, and then come and complain that we don't have and that when the money is allocated, that money must be used, maximally, and therefore spent in the year in which it's allocated, so that it doesn't have to go back to it. And then again, the issue that was raised by the AG, that on the wasteful expenditure, I think the machine that was purchased that became that was never used and became obsolete. That's the term. It's another issue that I think second military hospital, non-usage of medical equipment became obsolete, but the argument was at the time was due to ramp being finalized. All of these things, in one military, we bought equipments that could not be fitted in because the rooms were not made up to accommodate the equipment, but that equipment now has become obsolete in itself. So these are the challenges we are faced on that, colleagues. I don't think we can extend beyond this. I wish to thank you, DM and General Mapha and the team for engaging with us. We certainly sympathize with the situation. We will try to do what we can to bring your issue to the attention of the highest authorities. With that, we wish to thank all of you and colleagues. I DM you and the team, and you may exit the platform at any time you wish so, and whilst we move to the next item. Nandi, what is the next? Velam, what is the next item?
Chair, the next item, there were 2 sets of minutes for consideration.
Only the minutes, eh?
Yes, Chair.
Can we move minutes to the next meeting, colleagues? Agreed? I'm looking at time. We've gone over by 9 minutes.
Yes, no problem.
Yes, Chair. Yes.
Thank you, Chair.
Colleagues, thank you very much, and I wish you well as you go to sleep. We'll meet. Okay, next week, colleagues. Let me just deal with the next week issues. No, is the 15th. The 15th is a closed meeting. So the closed meeting must be in Cape Town because on the 14th would be in Cape Town, here in Cape Town, conducting an oversight visit to Summer's Town. So it's a portfolio committee going to undertaking oversight visits to Summer's Town, and then the 15th it's a closed meeting. So Nandipa and Velem, if you organize the venue, that venue must be in Cape Town, given that the team, the colleagues will be in Cape Town on the previous day, that is on Wednesday.
Yeah,
But
thank you,
colleagues-
Chair. Yes, we've started with that process for a venue at Parliament.
Okay. Thank you very much, colleagues. Until we meet again, the meeting stands adjourned.
Thank you very much, Chairperson. Have a very